So Gina, are you able to hear me again?
Yep, you're unmuted. Thank you.
Oh, great. And can you guys see this presentation?
Yep, your screen is being shared.
Great. Okay, so thank you everybody for inviting me, particularly Gina. I really appreciate your leadership on this and just giving me the opportunity to provide some information on COVID. I should start out just by saying that this is informational, and while I do know a lot about COVID, obviously the relationship that you have with your own doctors or a relationship that you might have with public health if you were to be exposed to COVID or get COVID would take precedence over anything that I'm saying. And so again, just keep that in mind. These are my thoughts as somebody who works with COVID patients every day and plans on a lot of different systems issues involving the treatment of these patients. As Gina mentioned, I'm doing this because I'm a son, and obviously I have parents who are at higher risk of COVID just based on their age, and also doing this as a father of children who I want to grow up healthy. From a professional standpoint, I have a medical doctorate, and I work as a physician north of Seattle for a large medical group. I also have a master's in public health and a background in epidemiology and sort of risk communication. And so my work now also involves being the medical director of one of three medical directors, I should say, of a large urgent care system. We practice really high-level urgent care, similar to some of the less trauma-based ERs actually in the area. And we see about 250,000 patients a year at my urgent care system. We're currently running about to run 4 clinics dedicated solely to the care of COVID positive patients or patients that think that they have COVID. I've also been a member of our COVID task force and what's called the subject matter expert group on COVID, which is a collaboration with infectious disease doctors, other public health officials, and infection control nursing to help make our clinic safe and help make our community safe. So that's just a little bit a background of what I do in my daily life. Obviously, I've been pretty busy. This is just a picture of my family and why we care. This is my mom and dad, and then their grandchildren. And I think the goal of this talk is to try to give you guys some strategies or an understanding of COVID and how you can continue to play pickleball safely and what it means to take care of each other in your community. So I just wanted to point out that we have survived pandemics in the past. Pandemic is a word that comes from the Greek pan and demos, which is affecting all people. And it is defined as an unprecedented medical, social, and economic impact illness. Our ancestors have survived pandemics, and we will also. You can see here that the bubonic plague probably killed 75 to 200 million people globally. And so at this point, this pandemic is going to probably be quite a bit smaller than these other pandemics that we've faced. So today, I just want to talk about the current prevalence and what it looks like to live and play pickleball in Pima County. We'll have a short review of the spectrum of illness. We'll talk about some strategies for minimizing risk and how playing pickleball can become safer, but probably not entirely risk-free. We'll talk a little bit about COVID-19 testing, and then also what an exposure is for members of the community and what a quarantine might look like. And then I'll definitely leave some time to take questions, and I can stay around for quite a while if we have to get through some detailed questions. So let's get right into it. So the prevalence in Pima County is not great, and you know, Arizona compared to other states is sort of coming out of a really high prevalence time. So far, the county has had about 37,000 cases and almost 700 deaths. This data is accurate as of yesterday. And I think that I would point out, if you look at this map of the counties and you look at where we are in Pima County, you guys are around 3,000 plus patients or people who have COVID out of 100,000. And so when you think of that number that they talk about in the news media, and they say that you want to get to so many per 100,000, there's a reason for that. And that's because the lower that number is, obviously the less likely you are to come into contact with someone who has COVID. And so, for example, our state was going to move out of phase 1 if we had a rate that was 20 per 100,000. And as you can see here, you guys are in 3,000 to 4,000 patients. And what that means is, in practical terms, if you see 100 random people a week, whether that's pickleball or in your community, you're likely to see 3 or 4 people who actively have COVID and are capable of transmitting that illness. So if you have a large pickleball group and you are on a number of courts and you are randomly seeing people 3, 4 times a week, you can pretty easily get to about 100 people. And at that point, you should assume absolutely that several of those people have COVID. Now, if that rate was down at 20, your chance of running into somebody who has COVID is about 2 in 1,000. And so vastly reduced. And so I think I should just state the fact that when you have high prevalence in the community, the activities you partake in are substantially more risky than if you have very low prevalence in the community. So my children right now are not playing with friends because our rates are over 125 per 100,000. But when those rates were 40 or 50 per 100,000, I was pretty careful, but I let them see 1 or 2 friends that they wanted to play with on a regular basis. And that was a safe thing to do, in my opinion. So if we look at who COVID is affecting, I think I would like to point out that it's mostly affecting white and the Latinx population in your county. And also, I would just like to point out the bottom graph, bottom left graph. And what you can look at is that cases kind of tinkered around in April, and then you guys had this massive surge in July. Things got better in Pima County, and then now things are getting considerably worse, and you guys are at some of the highest levels that you've had. This graph looks very different to us in the Seattle area, where we had a market peak in April and then a reduction, and we're actually now on our 3rd wave, and things are getting worse. You can also see that the bottom right graph shows that the death rate is actually improving. And a lot of that is because we know how to treat this illness better in our patients who are hospitalized. So that's very good news. Some of the medicines that are touted haven't been shown to have a significant effect in people who are already very sick and in the hospital. So the medicine remdesivir, the monoclonal antibody therapies, Regeneron, and the Eli Lilly product, those probably are useful to a small extent, but they're most useful if they're given early, actually, in patients who are probably not yet hospitalized or who are just coming into the ER. And our biggest bang for our buck is coming from actually the use of a medicine called dexamethasone, which is a widely available and very cheap steroid medication. So that's good news on the death front, but you can see we are entering for you guys a pretty significant surge. As far as the folks who are most affected, are patients that are 65 and over. And again, if you look at the severity of illness, the bottom right graph will show you that even though we have the most cases in patients that are in their 20s and 30s, that the patients in their 20s and 30s really are not accounting for the people who are dying from this illness and having severe disease. And so this is a calculated risk, and playing pickleball is not something you can do and fully eliminate your risk, but you can certainly be aware of how to minimize risk and how to do it in a safer capacity. So when we look at minimizing risk, we talk about washing our hands. So you can see these little Lego folks are washing their hands. And so let's talk about what you can do at home and what you can do on the court. This is a graph I put in there, which is a little bit busy, but it's a very fascinating graph. And I put a blue blob on the graph because I don't know how to annotate JPEGs very well. And you can see my blue arrow there. And what this graph is showing you is this is a whole bunch of common respiratory illnesses and how they vary in time. And so if you look in January of 2019, you see that we had all of these cold viruses. These are all the viruses that cause colds and flus. And they're chugging along here. And you come into the summertime of 2019, so you can see June of 2019, and you can see the rate kind of drops off. And then we get into winter, and all the viruses pick up again. And my blue blob there is showing you when in Seattle we had a mask mandate. And this is what happened when the mask mandate went into effect with all of the respiratory viruses. So all respiratory viruses just disappeared. And we had this dramatic reduction in influenza, other coronaviruses, rhinovirus, everything else that causes the cold just disappeared. So we know that something like masks works because we have the data that actually shows what happens in the general population. So in public, we've talked about all the ways that we can stay safe and stay healthy. The public actions that I've placed up here, these all come from your Pima County Department of Public Health. So I think we all know about not touching our hands, washing our hands. Pickleball is very interesting, and this comes from many of these, and this list is adopted for this talk from the USA Pickleball Association. And so we talk about players who might be returning from a tournament, or in your case, might be returning from other places in the country with very high rates of coronavirus being high risk. We talk about special considerations, what the board might consider or what you might consider about how to limit interaction during transition times on and off the court when you present to play and how you're actually going to get to your court. Sign-in areas, waiting areas. You guys have already done a very good job with that when I talked to my mom about how that works. But anything else you can do to minimize transition time. I actually think that playing pickleball in an outdoor environment is not nearly as high risk as the social aspects that go into playing pickleball. And that is to say the transition areas, the conversations before and after, any sort of gathering that would take place at somebody's house with pickleball friends, especially if there's any food or drink, certainly sharing common, salsa bowl or anything like that, as opposed to everybody having their own individualized plate of food or meal. Other things that I think make a lot of sense for pickleball would be everybody bringing personalized sanitizer with them as soon as they're done with an individual game, sanitizing their hands. Certainly not, high-fiving or touching. I think you guys already do a great job with that. Personal water bottles would be important. Bringing a handkerchief. And the reason I would do that is because we are all inclined to wipe our face, to clear our eyes of sweat when we're playing. And having a handkerchief for any sweat or any sneezing, and then retaining that, on your person or with your things would be a really good way to remind yourself not to touch your face. Consider the use of gloves. This was actually on the USA Pickleball list of considerations. Whether or not they're talking about using, a disposable glove when you're accessing the courts, high-touch surfaces, or whether or not they actually mean just using a glove while you're playing so that your hands aren't as soiled, and then removing that when you're done with play and sanitizing your hands. I'm not sure. I think both of those would be very reasonable infection control measures. Also, using different colored balls, if you could order them, or marking the ball, which I know you already do, so that the individual players are only serving with their own marked ball. And then another thing that I think would actually dramatically reduce your risk but may not be acceptable for how you want to continue play, would be to singles play. And singles play obviously would dramatically reduce risk because you can maintain 6 feet of social distancing in an outdoor environment at all times. Or if you have members of the same household, using them to play doubles. And then I think the other thing that you could think about in lieu of very strict measures like that would be cohorting your group. So could you have a set partner for the duration of a week or for the duration of 2 weeks? And if you were able to do that, that would also dramatically reduce the total number of people you interacted with inside of 6 feet, such that if there was a significant exposure, you would have to take offline much fewer members of the club. And so that might be something that you talk about and strategize about, especially when you're in a high-risk prevalence situation like you are now.
Hey, Andrew, I've had a couple people comment that your slides are showing the current slide and the notes slide. Is there any way that you can make it just the...
Yeah, let me see if I can do that. More slide options. Let's see here.
Yeah.
Hide presenter view. How's that? Is that better?
Now I can't see anything. It's a black screen.
Maybe that was a bad idea.
There it is.
Well,
the PowerPoint. The second one.
See?
That one.
Can you see this slide now? How to minimize risk slide?
No.
No. All right, I'm going to try something real quick. Hold on, bear with me.
Okay.
I think you went off screen sharing when you shut down the presentation. So you might have to share screen again.
Yes, I will share screen again. That is correct. And I took it down so that I could come out of presenter view, because I was in presenter view. So give me 1 second while I now try to get this back going. Sorry, you guys.
We appreciate your effort. Yeah, that's a lot better.
Okay, thanks, you guys.
Thank you.
So yeah, Gina, feel free to interrupt me with something like that, and we can.
Yeah, I'm just monitoring the chat. So we've got great people who are, and we're getting some questions. So you better get ready. Okay,
yeah, I'll be ready.
All right.
So the other way that I think you guys have already done this, but I think that there are some possibilities to perhaps make it a little bit better. And we've done this too with my clinic, is how do you screen people before they come in? In my case, how do you get people who have potentially a COVID infection to go to a clinic where they can be safely, where we have people wearing the correct PPE? And how do we prevent them from checking into a clinic with other patients who don't have any symptoms of COVID and who have high-risk medical conditions? And this is what we do. And essentially, these are a CDC list of questions that are common symptoms of COVID. But the other thing that we've done is we've added an exposure question, which is pretty basic, which is, have you or anyone in your household had a positive COVID-19 test in the last month? And what that does is it increases what we call your pre-test probability, or the chance that you have COVID before you even enter into these questions. And so someone who has had someone in their house who's tested positive for COVID recently, who has any of these symptoms, is at much higher risk of having COVID themselves and would be at higher risk of being infectious. And so, I would propose that asking these questions really every day that someone's going to play, and having people sort of attest to that, either through their own, personal agreement or the honor system, or even an online questionnaire or email or listserv or something like that, just to make sure, even posted outside of the courts, would be another way that we could limit the number of people that you could be exposed to. Remember that people are often pre-symptomatic for 2 or 3 days before they develop COVID. And in that pre-symptomatic period, they have virus that they can transmit. And so I think while many people, about 83%, become symptomatic and do eventually get symptoms of COVID, particularly in patients that are over 60, there is still always this pre-symptomatic period that this won't fully account for. So I did want to talk a little bit about COVID-19 testing because I think it's really confusing, and I may or may not get questions about this. So I'll go through this fairly quickly, but if there are questions, we can certainly come back to it because it is a bit detailed, and there may be some folks who follow these sorts of technical questions very closely, and other people that are just like, I don't really care what the doctors do. I just want to know if I have COVID or not. I think the most important thing to understand is that no test is perfect to diagnose COVID. And so most of the time when somebody comes in and they want to find out if they have COVID or not because they don't feel well, we perform a PCR test. And a PCR test looks for the RNA, which is the genetic material of the COVID virus. This is commonly done with a nose swab, but it can be done from a saliva sample or a tongue scraping or a sputum sample. But most commonly, we stick something in someone's nose and we look for the virus, and that's how we tell you if you have COVID or not. The problem is none of these tests are perfect. And so like with any medical test, we are only going to be able to accurately tell you if you have COVID, even if you have a fever and feel sick, about 70 to 80% of the time. What that means is that 1 out of 5 people who have a fever and have COVID are going to be told that their test is negative. That's not great. That's not great. So we would love to have a better test, but this is the best we have. I'm not speaking from my own clinic. I'm speaking nationally. This is as good as it gets. We know this because a lot of the initial data out of Wuhan province, we did CAT scans. The doctors did CAT scans. And if you compare our testing to CAT scans, where you can see very typical COVID imaging, you know that people have COVID on a CAT scan essentially 100% of the time, but you only get a positive PCR test about 80% of the time. So if somebody has a fever and has a cough, or if they don't have a fever, but they have some shortness of breath and a cough, or they just have a cold, they really should not be out in public. They definitely should not be playing pickleball, even if they have a negative test, because we can screw up 1 out of 5 people. And so now, if they feel better and they have a negative test, that's reasonable for them to re-enter public. But while they're sick, they really shouldn't trust a negative test. Now, repeating the test a couple of days later, that's very useful. And we do that all the time because 2 negative tests is a lot more predictive than 1 negative test. Here's the other issue. I just got off of an airplane and I want to make sure I don't have COVID from the airplane. You can't test for COVID the day or even within 2 days of exposure. There's no virus that's going to be detectable. So if I just came from Thanksgiving dinner and I want to play pickleball on Friday and I had dinner on Thursday, there's no test that anyone can do that's going to tell you if you have COVID or not. Asymptomatic patients, patients that do not have symptoms, really should be tested 4 to 7 days after exposure, because that's when the virus begins to replicate itself in significant amounts, and we can usually get a positive result. So the best time to test is 4 to 7 days after you're exposed, or 4 to 7 days after you actually start to get sick. Now, clearly, if you have significant symptoms and you're feeling short of breath, or you have a fever, you should probably go in and get tested, because the earlier you find out, the better. But keep in mind the ideal period of time, especially if you're not sure you're even sick at all, or if you just have rinky-dink little symptoms, is actually a couple days after you get sick, and probably 4 days after that exposure. The other thing that's important to understand is if you have typical symptoms of COVID, if you have shortness of breath, or you have a cough, or you even just have a cold, but you were coming from a high-risk area, high-risk activity, or if anyone in your household was tested for COVID, I don't care what your PCR test shows. I'm going to tell you that you need to self-isolate, that you need to quarantine, because if it walks like a duck, it quacks like a duck, it's a duck. And you can be told that you have COVID if you're in a high-risk exposure situation and you have symptoms even with a negative test. So very quickly, antibody testing.
Andrew, before you go on,
yes,
I'm going to insert one of the questions because it's related to this.
Yeah.
Are the PCR tests specific for SARS-CoV-19 or all coronaviruses?
The PCR tests are performed with 2 primers. Typically, these are specific for COVID-19 illness, which is caused by SARS-CoV-2. So they are not going to pick up other common coronavirus infections. They are, in general, they are highly specific. So this is a epidemiologic term. So they are not very, they are 70 to 80% sensitive, but when they are positive, they are highly specific for COVID-19. So if you get a positive result, you've got COVID. You don't have something else. You don't have a cold caused by a common coronavirus. Antibody testing is something entirely different, and that is only done after somebody has COVID for several weeks, and it can only look back and tell you if you've had an infection. And unfortunately, we don't know yet if that correlates to immunity. And so there's really no clinical recommendation that a doctor can give you based on an antibody test. You can come in and say, and I can tell you, everybody that I see thinks that they've had coronavirus. I really don't know anybody at this point that doesn't think they could have had it. And so everybody wants to get an antibody test. They range in cost between $50 and $150 in most places. And they might be able to tell you if you've had it or not. And those sensitivity and specificities from those is all over the map. The problem is, even if you test positive and you have an antibody test suggesting you may have had COVID in the past, we have no idea if it makes you immune or not, because these tests have not been validated. So we really have no idea. And so in general, we don't recommend getting antibody tests. They're just not very helpful because you might still be able to get COVID again. Now, there are some very rare complications that happen, like if you get COVID toes, doing an antibody test might be useful, but that's one of the very few reasons that I've ever done an antibody test for any practical purposes. The other thing that can be performed is a test called an antigen test. Antigens are not ready for prime time. You may have a situation where somebody says, let me test you for COVID. I'm going to use an antigen test. An antigen test is very, very poorly sensitive and specific right now. There's lots of false positives and false negatives. And for example, if you're flying to Hawaii and they require a test, they say you need a PCR test, which is the test number 1. Antigen tests really aren't good enough, and I wouldn't trust them before Thanksgiving dinner with, my high-risk sister-in-law, for example. I just wouldn't trust it. They're not ready for prime time. And let's shift gears, because I spent a bit of time on that, about a half hour into this, and I really want to get the questions. I'm sorry about Sorry about this.
We don't have anything else to do.
Okay. All right. So we're okay. So but please note, I will come back to questions on these, and we can go back to the slides at the question period if necessary. So I want to talk a little bit about exposures in quarantine, because I think these are also questions that come up commonly with a lot of my patients, and probably a lot of people as well. So people want to know if they get COVID, or if a family member gets COVID, when can I see that family member again? Or in our case, when can I go back and play pickleball? If I'm feeling well, when can I discontinue what's called transmission-based precautions? So for the majority of people who are developing mild to moderate illness, which is most people, and that is still most people over the age of 65 as well. You saw that graph, which shows that the fatality rate from COVID-19 is coming down dramatically, and people are now developing mild to moderate illness much more often than severe illness. For those people, when they get sick with COVID and they have symptoms of COVID, 10 days after the symptoms have resolved, as long as that person does not have a fever for 1 full day, and as long as they're feeling better, they can return to play. They can return to activity. And some people may have cold-like symptoms, a low-grade fever, that may last for 3 or 4 days. They may feel great after 5 or 6 days. Those people cannot come out of quarantine really under any circumstance unless it's a medical appointment until the 11th day. But on the 11th day, you should feel comfortable interacting with that person because they are no longer infectious on day 11. And I think that's really important. The reality is most people have peak symptoms at day 6. And so most people will start out with a relatively mild illness. Most people in their 60s and 70s will develop some sort of symptoms that are uncomfortable, like a flu, peaking around day 6 to 7 and then improving. But as long as they've had no fever for 24 hours, they're not taking Tylenol or ibuprofen for 24 hours, their cough is getting a lot better, and those symptoms started a full 10 days before, they can go back to regular play, regular activities, provided they feel well enough on day 11, on that 11th day. For patients who have more significant illness or severe illness, which is actually identified as patients who go to the hospital, going to the hospital and being admitted or being on supplemental oxygen, even if it's just a little bit of oxygen, even if it's, what Donald Trump had, he got checked in, the reports are there's a little bit of oxygen, not really a whole lot at all, just a little bit off and on. That technically is severe illness. Those folks are not on a 10-day, 24-hour return. They are on a 20-day, 24-hour return. So if you're hospitalized or a family member is hospitalized, they are infectious. They are infectious for 20 days. This also applies to people who are on things like steroids or who are on chemotherapy or otherwise immune compromising conditions. So people who develop COVID, who have significant medical conditions and know that they're immunocompromised, or who spend time in the hospital, can't come back until that 21st day. And they also have to be getting better for a full 24 hours. These folks clearly should be in contact with their doctor so they can get individual recommendations. Now, what about the people who don't even know they have COVID? They get tested because somebody in their family was sick and they truly are asymptomatic, because that will happen. And if it doesn't happen to you, you will probably know people, children, grandchildren, who really didn't know they were sick. for people who never develop symptoms and who simply have a positive test, they are much like the first group in that they can't return to play or return to public until they have had 10 full days from their diagnosis when they first tested positive. So they never get sick, so they don't really have a day one of symptoms. So you've got to go to day one of symptoms is the first day they tested positive. So even if they feel just fine, they really can't go out in public until that 11th day. So then it comes up, well, thanks, Dr. Richter. You just gave us all this information about when we can go back and play pickleball again if we're not that sick. And I got sick, but now I'm clearly getting better. 2 weeks later, I want to go back and play. Well, someone told me I need a test to come back and play. And the answer is, that's probably wrong. You almost certainly don't need a test to come off of transmission-based precautions. And the reason is that I can stick a swab in your nose and I can find virus for a long, long time. And just because I can find bits of virus, bits of RNA at 3 weeks, 4 weeks, 5 weeks, we have had patients where I work in some of our trials. One of them was published in the New England Journal of Medicine that test positive 3 months after their initial infection. But a fragment of virus does not correlate to infectivity. And the CDC has done studies where we take these samples and we put them in a very nice environment called viral culture media, and we try to grow those viruses, and we cannot grow virus at all, period. These people do not have what is termed replication competent virus after 10 days, assuming they have no fever and they are getting better, and assuming they're not immunocompromised and didn't have illness severe enough to wind them up in the hospital. You cannot give people this virus just based on a positive test. And therefore, testing them is useless because you can have people for a month told that they can't do anything in public, yet they can't give it to anyone. This is especially true, in younger patients and children who have minimal symptoms. They still can't pass this on. They have a robust immune response. And we see this in other illnesses too. Chlamydia is a great example. I mean, I hate to use it as an example, but we will have patients who test positive for chlamydia who start accusing their partners of giving them chlamydia again, and they can't give people chlamydia again if they take their antibiotics. They're not infectious after a day of taking antibiotics, but we can still detect the viral fragments, in that case, the bacterial DNA fragments, for several weeks after the person has been treated effectively with antibiotics. So we have a lot of workplaces. Boeing up here is a big one. Boeing required, repeat testing. We don't have the resources to do it. And it's not only us, it's the entire country. We don't have the swabs, we don't have the transport media, and it's not evidence-based. So we have met with Boeing and their occupational safety and health, and they no longer do that because they know it's not scientifically based recommendation for the vast majority of patients. Again, there's an asterisk. If you're critically ill or immunocompromised, there may be a role to retest you. And so I'm not speaking to patients or players who have these specific carve-outs. So then the next question is, well, how do I know if I've been exposed? What do I do? What is an exposure? And so I think focusing on the blue bar up at the top is probably the most important. And that is the definition of close contact. And a close contact is someone that you have been within 6 feet from for a total of 15 minutes. And that 15 minutes is in any 24-hour period. So that's why things like not congregating in a common space, not sitting next to people, in between games inside of 6 feet. That's why your partner inside of 6 feet, where you're generating a lot of potentially aerosolizing droplets or aerosolizing discharge from your mouth and nose, is something to consider all the time, because that 6 feet is not, it's actually pretty far to maintain that, and then you've got to maintain that, and you can't violate that for a total of 15 minutes. So it's cumulative, and that was a change in late August. The CDC actually changed that recommendation, not just 15 minutes at any given time, but any 15 minutes all stacked up in a cumulative 24-hour period. The other thing that I think is really important is the note on the bottom left of this slide, and that was a change as well. And it's an unfortunate change, but it's an important one. And that says that this is irrespective of whether the person you were with was wearing a mask or not. So if you sit down with a family member who is diagnosed with COVID the day after you have lunch with them, or the day that you sit next to them and talk to them, and they were wearing a mask, the mask doesn't save you. You were still within 6 feet for a total of 15 minutes because you guys had a nice conversation and you were outside. You still were exposed if that person is diagnosed with COVID within 48 hours of you hanging out with them, and you're now on a quarantine. And so masking is important for healthcare workers, and the thought is that masking in the healthcare environment, you use masks that are not, a nylon stocking that you just cut off and put over your face. It's not some cheap, piece of cloth with holes in it. It's not an N95 that has an outlet valve that protects the wearer, but doesn't protect you at all. And so the CDC removed masking from being a consideration in the community setting. So that would apply to pickleball as well. So again, inside of 6 weeks for 15 minutes or more. That's the definition of an exposure. If you were exposed, then you need to stay home for 14 days after the last exposure. We really want you to maintain 6 feet of social distancing at all times. Try not to leave the house except for medical appointments, and self-monitor for symptoms and fever. So there's a couple of examples here that I threw up. So the question is, well, what happens if I was exposed to somebody on Wednesday at pickleball and they were my partner and I played 4 games with them and we were inside of 6 feet and we took our masks off to play pickleball? Actually, even if you had your mask on and you were playing pickleball in the community, you'd still have an exposure. And so this is what you do. Well, I'm not going to see that person again. I played with them on Wednesday. I'm not going to see them again. And so I am out of quarantine and I can play pickleball again on Wednesday the 15th. So it's a full 14 days and I can come out of quarantine on that 15th day. So that's fairly self-explanatory. It's a long time. The odd thing is, and this is important, I just told you that if you had COVID, you could come out of quarantine and start playing with people on the 11th day. And that's true. If you have the illness and you recover, your period of isolation is shorter than if you have an exposure. Because at any time in that 14-day period, after you've been exposed, you could harbor the virus and start to get sick. And you could transmit that virus very easily for 2 to 3 days before you actually become sick. And so your quarantine period is actually longer from an exposure than it is for an illness, which is weird, but very true. So what if you live with somebody or have a close contact with somebody? How long do you need to be quarantined for? Well, hopefully public health will contact you and they'll give you this advice because you live with someone who has COVID. Well, if you're with them and you can't separate yourself from that person for, let's say, 4 days, your 14-day period of quarantine doesn't start until you have removed yourself from that household member. And so you need to find a separate bathroom, a separate bedroom, not eat with that person or share food with that person. And when you're inside of 6 feet in the same room as that person in your house, you do both need to be wearing masks. But the bottom line is your quarantine doesn't start until you're no longer exposed. I think I have 2 slides left. If you live with someone and you cannot avoid close contact, maybe they're your spouse or your partner. Maybe you have to help take care of them because you're worried about them and they're sick, and you do the best you can. And you're wearing masks at home, but you have to be inside of 6 feet, and you can't really get a separate bathroom. You can't isolate. Well, then your quarantine period starts as soon as they're not infectious. So they've got to go through their 10 days because you could be exposed to them on their 10th day of illness. And so your 14 days doesn't start. This is my worst fear. One of my kids gets COVID. They're a kid. They're going to be fine. I'm not working for 24 days because I can't get away from them because I have to care for them. That's a very, very long time if you can't get away from somebody who has COVID. So what does the future hold? I think ideally we would get some antigen testing that is very effective. And if we can get excellent sensitivity and specificity out of an antigen test, you could get a test result within 5 or 10 minutes, and that test would cost you $5. And so if you want to go out and have happy hour at the local Mexican restaurant, if you could pay $5 and everybody in your party got an antigen test and in 5 minutes you all tested negative, you may not know if you're going to get COVID in the next 1 or 2 days, but you would know if you're infectious right then. And you would know if you could get those friends sick for 4 hours. That would be awesome. And if your airplane ticket cost, $15 more and everyone got an antigen test right when they were boarding the plane, or everybody who wanted to see just an incredible football game with the Seattle Seahawks, you could all get an antigen test right before you walked into the game for $15 more for your ticket. That stadium would be extremely safe for the duration of that football game. So that's one thing that I hope the future holds. The second thing is vaccination. We've got reports now on 3 vaccine candidates. All 3 have applied for what's called emergency use authorization. 2 of them are the Moderna and the Pfizer. Those show 94 to 95% efficacy in early data that's been released. The Moderna, that trial looked at people that actually were over age 60. It looked at a very diverse group, and the immunity looked robust in those populations, which is fantastic news. And then unfortunately, we really don't know what the future holds. These are all different scenarios that were postulated back with the H1N1 2009, and we're absolutely seeing scenarios just like this with COVID. Unfortunately, I would say that we have a large second wave, and right now we're seeing a large third wave, which is actually higher than the initial. And so that's kind of where we're at. So I'm going to stop there. I just gave you guys a lot of information about COVID. And so I am more than happy to take questions. Maybe we should start with a chat window first and then open it up to audio questions. You're muted, Gina, so I can't hear you, but I know you're talking.
If you're good to go through the chat window, that's fine. I've had some people send them directly to me as well, so.
Yeah, sure. Do you want to ask questions out of the chat window and then we can unmute and ask audio questions?
Okay, I've got them written down here. So some of these I'm going to put together, but it relates to GVR and what the staff is doing, spending lots of time cleaning surfaces, gate handles, that sort of thing. Also, the water fountains are not in use. And then just in general, transmissivity, airborne or surface, what's the worst or best or however you want to look at it. So can you do all 3 of those?
Yeah, so what GVR is doing is fantastic. I mean, we definitely know that decontaminating or disinfecting high-touch surfaces is critically important. We also know that what's called fomite transmission, or transmission on inanimate objects or surfaces, is probably not the main mechanism of transferring this virus. So we should be clear, it can happen that way. And if somebody, sneezes in their hand and touches a door handle, and certainly if you have several hundred people touching a door handle in rapid succession, you can have transmission. And so you do need to wipe those down. Now, am I worried about, my clothes or my shoes, 4 days after I work in a COVID clinic? No, I'm not. And that's because, generally speaking, surfaces don't retain viable virus for very long. We haven't pinpointed how long that is, but I think, in general, a couple of days, especially exposed to direct sunlight, is a very long time, and this virus does not last very long on those types of surfaces. Turning off the drinking fountains is also a good idea, because you could see that you have rapid succession use of the drinking fountains. And so bringing your own water bottle and your own sanitizer, those absolutely contribute to your overall safety.
And would that also count for the touchless type fountains, where you just put your receptacle there?
Yeah, so that's a good question. I was kind of hemming and hawing, because I thought, anytime you put your, face into something, and, I slobber, and so I don't know that you can, I don't know that you want to drink out of something, but using a water bottle to go into a touchless environment and fill up the water bottle, that's probably relatively safe. Yeah.
Okay, I hope GVR heard that. All right, let's go to the next one. You did have some information about Pima County. Did you have anything in particular about Green Valley as far as statistics?
It's interesting. I don't. The answer is I don't. I tried to look by zip code, and there are some significant differences by zip code, but because I don't know that you're an incorporated city based on 2010 census data, so I can't get the information for that reason. And I don't think you will either. I do think it's important to recognize that you have a lot of people traveling from all over the country. And when we get folks traveling from really, really hot spots, hotter than Arizona in the Midwest, you have to be very, very cautious, because those rates are very, very high. You also have folks coming in to help take care of things, whether it's landscaping, air conditioning units. Anytime you have folks coming in, you could have family members coming. My family, we were supposed to see one other family only at Thanksgiving, and we canceled that because the rates are high. And even though that other family is safe, we did not feel that another family of 5 was a good idea. And so you're going to have families come in based on your own risk assessment into your community. And so it's very difficult for me to view you as completely isolated from the county when we know that there's interaction at stores and gas stations. And so I think everybody needs to take that into consideration.
So if somebody is coming from another place, but they don't believe they've been exposed to COVID, do they still need to quarantine, like if they're coming from a hot spot?
So that's a great question, and I don't know that anybody has the answer. I would say that there's no question different municipalities have taken a different approach. In Washington State, our governor has issued a statement that if you travel from out of state to Washington State, which again currently has about 10 times fewer cases per 100,000 than Pima County, then you are supposed to self-quarantine for 14 days, unless it's for essential business purposes. So I don't believe that Arizona has that mandate, but Washington State does. And so you have to understand that that is probably a very reasonable public health stance to take, but that is not something that I can speak to specifically for your county or where you live. There is no question that those attestation questions, that personal attestation to not having symptoms and not having a known contact, would be very, very important for everybody to take seriously, and that would minimize your risk. And ideally, people that travel from a high-risk area would decide to self-quarantine, but I can't make that decision or that specific recommendation for GVR.
And along those lines, is the app that like Apple and Google tried to come up with, the contact exposure, is there any efficaciousness with that, or are they working?
Yeah, I don't have enough information to answer that specifically. There was some initial information that came out suggesting that the data wasn't specific enough, that, for example, you may have been around somebody in one environment that, was safe, and another environment that wasn't, and it wasn't going to tell you enough about distances and things like that. But that is in its infancy. I think it has the potential to be a very powerful tool, but that's not validated anywhere to my understanding yet.
Okay. All right. Let's see here. Should we be considering wearing masks while playing?
I mean, again, I think the CDC won't use that for sparing you from the definition of a close contact. So we know that mask use in the community isn't enough inside of 6 feet to spare you from potentially acquiring COVID. But we also know that there's no question that even though it might not be good enough to spare you a close contact, it definitely does reduce transmission of virus. So there's no question that wearing masks works. There's also no question that masks aren't all created equal, and that wearing masks that aren't made out of a nylon stocking are, you can get masks that are much more beneficial. And anytime you reduce droplet transmission, you're going to reduce contagiousness. So I think you should consider that. But that, again, is not something that I feel comfortable answering for all of GVR. It's certainly an individual consideration, and it does have benefit. There's no question about that. It does have benefit. And it's not just the person wearing the mask to protect themselves. It's about source control. So an asymptomatic patient is not transmitting as many droplets wearing a mask of any kind. We also know that this is primarily transmitted through droplet, but there is an aerosolizing or at least an airborne component to the virus, but it is a relatively minor component, especially in the outdoor play environment. So outdoors with incredible, quote, air exchange, you're not in a small contained space indoors. Outside is much safer. There's no question about that. So there's not likely to be that much aerosolization or buildup of aerosol. And we know, again, that time, distance, and air exchange are actually more important factors than wearing a mask. But masks do work. So I know that's a very convoluted answer, but those are all very important points.
Well, it's a convoluted answer that has caused our interim CEO to want to ask you a question. Go ahead, Jen.
Hi, Dr. Richter. I really appreciate your presentation this evening. It was so educational for me, and I hope for everyone in the room. As the interim CEO and trying to navigate this horrible time in our world, do you have any advice for us about how we can make sure that we can keep people safe, but also let everyone enjoy their life and kind of find that balance? It's a tough thing to figure out. And if you have any input, it would be awesome.
Yeah, I mean, I really appreciate you letting me have the opportunity to speak to this group. And so really thank you very much. And thanks for allowing me to share this information. I think this is a really hard question, and that's why you're struggling with it and everybody else is struggling with the same issues. You know, locking somebody in a room in their home and having people deliver groceries to their door for the next 6 months is certainly safer than playing pickleball. But it certainly is not necessarily the right thing to do. And in fact, that can have significant harms as well, because people are isolated, they're not getting exercise. When they come back to activity, they're going to have a much higher chance of injury. And so I think we need to be very careful in making blanket recommendations, and doing the quote safest thing is not always the safest thing at first glance. And so I think a couple of points should guide whatever recommendations you come up with. And the first point would be that prevalence is a very, very important consideration. And some activities, when there's a low prevalence, are quite safe. And those same activities might be more dangerous, or a lot more dangerous, when the prevalence is high. So having an understanding of what is going on in the local community might allow individuals to make a decision about what kind of risk they're willing to accept. And so the idea for a CEO might be to be very honest. There's nothing we can do to fully eliminate your risk, but I want to communicate what the public health department says about pickleball. I did not find information about pickleball on the Arizona Department of Health website. I do have information for Washington State about pickleball. Outdoor pickleball is considered a low-risk athletic activity. That is different from other activities that are considered high risk. So wrestling and basketball indoors are considered high-risk activities. So I would recommend that you don't start a wrestling club at Green Valley. I know you wanted
please
to,
no, please
but I have
no.
to put a hold on that. So I would come down to what the prevalence is. I would express the prevalence and have people try to make the best decisions they can about their risk. And someone who's 60, who is in incredible health and doesn't have any chronic medical conditions, may be willing to take a risk. Similarly, someone who is that age that has complex medical conditions but is okay with where they're at in their life may be willing to take risks because severe illness is a risk they're willing to take. Right now, you guys have a pretty high prevalence, and I'm nervous about my mom playing pickleball, which she does multiple times a week. And you know, I know she's taking hand sanitizer and she's doing the best she can to limit her risk, but it does make me nervous. And I think if your prevalence was 100 out of 100,000 instead of 3,000 out of 100,000, I would actually be fine with her and I wouldn't worry very much at all.
Thank you for that. Thank you for that. So my next question would be, you know, a lot of our members and most of them say, hey, you know, I'm capable and I'm willing to take my own safety into my own hands. But I see the numbers rising, and I'm, you know, it's not just pickleball. It's not just bocce ball. It's not just the fitness centers. I've got like 30,000 people that for the next 6 weeks, I'm still making the best decisions I can. And it worries me. So
yeah, it's a very tough time, and the prevalence rates are really high. It should worry you.
And they keep rising. And, you know, I get the people that say, oh, we've got to shut everything down. And I've got the people that say, it's my decision. And so I know you can't answer my root question, which is, am I doing the right thing? But I feel like your presentation this evening, I really appreciated. You gave us some really good facts. You gave us some good information. I hope everyone heard it. I wish we could broadcast it to all 24,000 people, because what you said, you got to take it in your own hands, but it's also, you need to also be very careful. And I think,
well, let me add one thing to what you said. So, you know, I think the decisions that you or the board make when you have a really high prevalence, they can be different than when you have a low prevalence. And when you're in a period where rates are increasing, and we know that, you know, if you see 100 people in a week, that 4 of them are going to have COVID, you need to be very, very careful. That's a very, very different thing to consider, because right now, you know, doing one activity, again, might be a really bad idea, but in 5 months, it may be totally safe. The other thing that I want to point out, though, is that whether or not you individually decide to take part in an activity that puts you at risk, and any activity will put you at risk. It's the degree of risk that you're willing to accept as an individual. But the other part of that is you have an absolute responsibility to everybody else. So understanding the prevalence and deciding to participate or not is half of the equation. The other half of the equation that I don't think that there's any wiggle room in as a doctor is, if you feel sick, if you can't take your temperature in the morning before you go to do an activity, if you can't attest to having no symptoms, if you have had a positive contact and you decide not to quarantine, those decisions, in my opinion, those are really unacceptable. And those things, I actually believe, as an interim CEO and as a board, you absolutely have a responsibility to make those recommendations. You can't police everyone. You don't have the way to necessarily enforce or track every individual, but I think those need to be the accepted standards by which everybody else can live, and those probably do need to be absolute, again, in my opinion.
Bravo, thank you. That is exactly what we're trying to do. Thank you. Thanks, Gina. I will mute myself. I don't
All right.
wanna...
Thank you. All right, let's pop back. We've got some more questions here. How effective has a combination of remdesivir and I can't say it, BARICIT, NIB, been in treating patients with COVID?
Yeah, so remdesivir is one of those. Both of those drugs, I can't speak too much to the. I actually can't even pronounce the generic term of the B drug. But remdesivir is interesting. You know, it had a lot of promise at first. It does tend to reduce the severity of the illness if given earlier, and the reduction in illness severity isn't that great for the overall cost of the medication. And in fact, you know, you get very little bang for your buck. Dexamethasone, which is extremely cheap and can reduce mortality, significant illness by 40–50%, surprisingly is much more widely available and vastly cheaper and probably much more effective.
Okay. I think we're getting down to the end here. I think we know the answer to this, but if you could just punctuate it one more time. If our entire group is less than 20 people, does that minimize risks?
Sure. I mean, again, anytime you can limit the number of people and cohort people, the better off you'll be. So from a public health or epidemiologic standpoint, you know, again, if you have the same 2 or 3 partners for the course of 1 or 2 weeks, and those were the only 2 or 3 people you came in within 6 feet of, then you are effectively narrowing your group and vastly reducing your exposure. So yes, 20 people is a bit arbitrary, but yeah, if you had courts, for example, or a system where only the same 20 people showed up and moved together in that group of 20 throughout the week, that would give you much less exposure chance than if you had a group of 100 people together at a large site, and if that was changing every day. So there's no question that those types of strategies limit your risk. They don't eliminate it, but they reduce it.
Okay, I think that's it. Let me just double check somebody tell me if we've missed a question. Oh, no, there's some more in here. Okay, hold on.
There's some really technical questions in here too.
Yeah, you see them. You want to just take them as you see them?
Yeah, I mean, I really, there's one question about luminescence in vaccines. You know, I really don't know anything about that, and I have read nothing about that. I don't believe or have any working understanding that there's any way to identify people who have received the vaccine or not. And so I just can't speak to that. I did speak a lot to the face covering, and it is still considered an exposure in the community setting, but it is not in the medical setting. Vitalant and ARC test, your blood donation. This is just an FYI. Yeah, I don't actually know what we're doing as far as screening our blood supply or what our blood centers are doing to screen for COVID. I can't speak to that either. That's not my area of expertise. What do we do to proactively minimize our risks besides masking, hand washing, and social distance? Are certain supplements recommended? That's a really great question. I don't know that we have enough data on this. We do know that in some respiratory viruses, use of zinc and stuff can help reduce their ability to bind to your throat and other mucosal tissues. But I don't know that we have enough information yet to really make a recommendation. There's been some weird stuff like, do certain supplements work, like oleander or other supplements? And we don't have enough information. And so I can't recommend them. Definitely improving your immune system function should help. And those are things like being active and staying healthy, minimizing your chronic conditions, controlling chronic conditions if you have them, getting lots of sleep. I mean, those things make a big difference. I would also point out that mask use and PPE use is probably the least effective. And the most effective things you can do are environmental controls, like outdoors, air exchange, social distancing. Again, those are more effective than masking to do those sorts of controls. So, and I think that wraps up the chat.
Yes. Could you just address sunlight?
You guys ask really good questions. So I'll just
what about
thank
sunlight?
you, everybody.
What about sunlight and the virus?
Yeah, UV light from the sun, natural UV light, or actually they sell systems. You can drop your cell phone into certain systems to decontaminate them. They have this at certain, certain health visits and stuff. Though that works, and this virus does not like sunlight at all. So you guys live in a great place. Where I live, not so great. So yeah,
okay.
we actually, yeah, thank you.
All right. Well, are there any other questions that somebody wants to ask before
Nina. Ms. Campfield has her hand raised.
I don't see her on mine. Go ahead, Nina.
Okay, thank you. I want to clarify. So, for example, I get 2 situations. One, going on a hike where you're not seeing, it's not crowded. You pass people occasionally, but you don't stop and talk to them. And you try to whether there's 6 feet of distance available or not, is that of concern?
Yeah, I would view most outdoor, most hiking as very low risk. That is a low risk activity. And you're right. If you're passing people quickly and you're not, dilly-dallying at an overlook, you're not reading an interpretive sign and standing next to people, and you really are just hiking and you are being diligent to pass people quickly, that's a very low risk activity. If you're hiking in a group and you guys are talking over the course of a couple hours and you're inside of 6 feet, certainly at that point you are, exercising, exhaling. That's a bit different. So I would be very cognizant as to the size of the group you're going with. A very small group of people, particularly if it's a group of people from your own household, that's extremely low risk. And passing other small groups quickly on the trail, not risk-free, but I really think the benefits there probably outweigh the risks. As far as hiking with one other person, for example, I would try to hike next to that person as opposed to directly behind or directly in front of. And if you can maintain 6 feet while you're passing, that's great. Or if you can maintain 6 feet before or in front of, that also dramatically reduces your risk. But again, that's an outdoor activity with very low risk. Great question.
I think there was one more that popped in there. If you could see that, maybe a couple more. I can answer the link question. We are going to post this recording on the pickleball website and then the GVR website. I understood you to say masks were least effective, correct. Is there a reason to wear them going to and from cars or buildings?
Yeah, so let me just restate this. Masks are an effective way, and they definitely reduce your risk of getting COVID. They definitely reduce your risk of giving COVID to loved ones, because droplets are the most important way that this virus spreads. And even if it is aerosolized, it still behaves a lot like a droplet illness. So masks still help. They still work. So yes, wearing a mask in a store, wearing a mask while you're going to the store or walking through a parking lot, getting out of your car where you may come into close contact with someone. If you're not exerting yourself and you can wear a mask and it's not prohibitively uncomfortable for the activity, I would say absolutely wear a mask in public. It will help. Is it as good as being outside? No. Is it as good as staying 6 feet away? No. Is it as good as limiting your time from somebody? No. Those things are most important. Having dinner with a bunch of friends indoors in a high prevalence community without masks on is not a good idea. Putting masks on probably won't help you all that much. So it's not that they're not important. It's just they're not as important. Sorry to beat that like a dead horse, but I just want to make sure that I'm understood.
No, that was really good. I think that's it. Oh, hold on. A lot of thank yous. Yeah. So you are okay with us posting this recording? We didn't get a signed document from you or anything.
That's fine. I don't care. Okay. I talked to my chief medical officer and ran it by her. And I don't need to talk about where I work or anything like that, but I have a lot of experience with this illness. Yesterday I treated 10 patients yesterday with COVID and continue to do that. And we're being, overwhelmed here. We have positivity rates that are upwards of 20% right now in my clinic symptoms, somewhere between 10 and 20%, depending on the day. I track those rates daily. And by way of comparison, this summer we were at 2 to 3%. So I'm personally very concerned going into the holidays. I have many patients that return from, girls' weekend to, local vacation spots where they just go with 5 people. And 2 days later, someone has COVID and now, half of that group is exposed. And this is constant. And what I really worry about is our hospital situation. In Arizona right now, you guys are in the red zone as far as hospital beds. And what that means is that you don't have the capacity in your hospital beds or ICU beds to accommodate 2 times the volume of COVID patients that you have now. And that's the benchmark that your state has elected to use. And you are not meeting that benchmark. And so what really worries me is what happens in 3 weeks, 4 weeks. Keep in mind, it takes about 7 days or so before people really get sick and go to the doctor after exposure. Then it takes another week before people generally require inpatient care. And so we're talking about 2 weeks before people end up in the hospital. Then it takes another week before those people on ventilators pass away. So anything that happens over Thanksgiving, we're going to find out right about Christmas. And my biggest fear is that we're not going to be able to take care of people who have COVID, but we're also not going to be able to take care of people who have chest pain or who break their leg or anything else, because we will not have the capacity if those types of tests, percent positive rates continue to increase. So please, if you can make personal decisions that protect yourself and protect your family, please do them. My nurses are crying and begging me for more staff, and we don't have it. So just please keep that in mind.
Dr. Richter, this is Jen. I just want to thank you so much for spending your time this evening. I know I'm interrupting Gina, but oh my gosh, what you said tonight is so much more eloquent than anything I could have said for the last 8 or 10 months. And I really appreciate you spending the time, and thank your parents for bringing you here. And I hope someday we'll get to meet and get on the other side.
6 months, you guys. You'll be able to do mostly whatever you want. I really believe that. I think these vaccines have unbelievable promise, and I can't stress that enough. It's the thing that's getting me through this. So, thank you, everybody. Really, just have a great night, and feel free to pass questions through my parents if they come up.
Well, maybe we could put you on the hook for a sequel in 6 months. You're going to come back and
I can come back
if
if there's demand. I don't know if I'll still be in Greece, but I'll do my best.
You know what? I'll buy you dinner if you're in Green Valley.
Okay, everybody. Thanks, good. Everybody.
Thanks, you guys.
We'll promote the video, and I have a feeling this will be good for everybody. Go ahead.
All right. Happy Thanksgiving, you guys. Bye-bye. Be safe. Wash your hands.